even if pain exists in the absence of tissue damage, it doesn't mean that somebody's making it up or faking it or imagining or malingering, right? It doesn't mean any of that. And kind of back to your point, Gordon, that just because we can't see it doesn't make it real. Like it's absolutely real. And just because it's being generated by our brain doesn't make it less real.
This episode is sponsored by TherapyNotes, therapynotes.com. Be sure and check them out and be sure and use the promo code Gordon, Gordon, and you can try them out for 2 months for free. For the past 20 plus years, I've been working in the mental health field as a licensed therapist, private practice owner, coach, and consultant. And I've learned a lot the hard way, and I don't think you need to do the same. Hi there, I'm Gordon Brewer, and welcome to the Practice of Therapy podcast, part of the PsychCraft network of podcasts. Whether you're just starting out, expanding your practice, or looking for fresh inspiration, this podcast is here to support you in your journey. Each week, we explore the real-world challenges and opportunities that come with building and growing your private practice. From marketing and money management to ethics, client care, and self-care, we cover it all. You'll hear from leading experts, seasoned clinicians, and innovative voices in the mental health and allied health fields, all sharing their insights and strategies to help you thrive in your practice. So let's jump in and get to today's episode of the Practice of Therapy podcast. Folks, it's Gordon Brewer, and welcome to the Practice of Therapy podcast. This is episode number 419 of the podcast, and so glad you've joined me for this particular episode. I'm looking forward to you hearing from one of my good friends, Dr. Melissa Tiessen. I've known Melissa now for a few years, and she is located up in Canada and is doing some just really fascinating work now with neuroplastic pain. And so we talk about that in this particular episode. You know, I think most of us are familiar with neuroplasticity and that whole concept. Melissa is doing some great work just around pain and how we can use treating the neuroplastic sides of our brains to help with people that are experiencing pain in different ways. And so it's an interesting topic, and I was really glad that Melissa reached out to me to talk about this particular topic. So before we get to that, though, if you're interested in working with me just one-on-one and doing some consulting, I'd love to talk with you about that. You can reach out to me by going to practiceoftherapy.com and just click on the link there that says coaching and consulting, and you can find out more about how you can do some work with me individually. I enjoy working with people on different aspects of running a private practice. Maybe you're feeling stuck in some particular area, or you're really just looking at how you can grow your practice or diversify, ways of diversifying your income streams, or also scaling your practice. So love to hear from you. And what we can do first is just schedule a one-on-one 15-minute brainstorming session where we can just talk about the things that you're working on and look to see if you might be a good fit for each other and just working together. So no obligation there, but love to have that conversation with you. And also, before we get to my conversation with Melissa, I'd love for you to hear from our sponsor of the podcast, TherapyNotes.
Hey there. Are you searching for answers and clarity on your mental health journey? Well, I've got the podcast just for you. Welcome to Finding Your Way Through Therapy, a podcast that's like having a heartfelt conversation with a trusted friend and who understands what you're going through. I'm your host, Steve Bisa, a therapist and proud member of the PsychCraft network. Finding Your Way Through Therapy is a safe space where we openly explore the emotional complexities of mental health. From busting common myths to sharing actionable advice, we'll navigate this journey together through solo episodes as well as special guests. Discover your inner strength, resilience, and hope as we explore topics like self-care, building healthy relationships, cognitive behavioral therapy, and overcoming challenges. You'll come away with a renewed sense of self and the tools to create a life filled with fulfillment and well-being. So join me on Finding Your Way Through Therapy as we become your companion on this deeply personal journey. I am part of the PsychCraft Network and truly enjoy all the episodes. And back to your regular scheduled programming.
Hi, this is Rachel, Gordon's podcast assistant, and I want to share the platform Gordon trusts for his own practice, TherapyNotes. TherapyNotes is the highest rated EHR, practice management, and billing software for mental health professionals. It's an all-in-one system for scheduling, notes, billing, and secure client communication. And if you ever need help, their 24/7 customer service is always just a call or email away. Their latest update, Therapy Fuel, uses AI to streamline documentation, generating progress notes, creating contact notes from client messages, and even summarizing client history forms, saving therapists hours every week. Are you ready to give it a try? Head to therapynotes.com, click Start My Free Trial, and use the code GORDON to get your first 2 months free. See why TherapyNotes is the most trusted EHR and the one Gordon chooses for his practice. Please enjoy the rest of the show.
Well, hello, everyone, and welcome again to the podcast. And I'm so happy to get back on the podcast, my good friend, Dr. Melissa Tiessen. Welcome, Melissa. I'm glad you're here.
Thank you so much, Gordon. I'm so happy and honored to be back.
Yes, and Melissa is doing some incredibly interesting new work, and I'm going to let her tell you all about that. But Melissa, as I start every time on this podcast, for people that don't know you, tell folks a little more about yourself and how you've landed where you've landed.
Yeah, sure. So I'm a clinical psychologist. I work in private practice. Actually, I see people exclusively virtually in Ontario, Canada. But I live in Manitoba just to keep things interesting. And I have been a psychologist, a registered psychologist of over 15 years now. Always hard to believe when I think about that. Grad school reunion is being organized for this year, our 25-year reunion since starting. So I don't know how that happened because I'm only 29. So
yes.
Anyway. And yeah, in my clinical work, I focus primarily on treatment of chronic neuroplastic symptoms. And I also have a side business with my dear colleague, Dr. Karen Dick, which is focused on therapist self-care and well-being. And of course, Gordon, you were kind enough to have us on your podcast in the past to talk about that.
Yes. Well, Melissa, I'm so good to catch up with you again. And this, I think probably the people that are listening have at least heard the term neuroplasticity, if I could get it out of my mouth. But this is something specifically related to pain. And so tell us about it and maybe give us a good overview of what this kind of cutting edge kind of research is all about.
Yeah. And so that's a great point, Gordon, that many people are already familiar with the term neuroplasticity, especially working in mental health. And so that's a great place to start because it really highlights exactly what this approach to the treatment of pain and other symptoms is. So, of course, neuroplasticity refers to the changeability of our brain and our neural pathways. And so what neuroplastic pain refers to is essentially pain that isn't caused by tissue damage or some sort of structural issue in our body, and instead is caused by how our brain and nervous system are wired to respond to threat. And so this is such an important concept because it really introduces this kind of new possibility that when people are experiencing chronic symptoms, and of course, this doesn't apply to every chronic symptom, but it actually applies to a surprisingly greater number of chronic symptoms than most people realize. So once people understand that this idea can in fact apply to all kinds of chronic symptoms in our body, it opens up this brand new possibility that these symptoms can be changeable. Again, the plasticity part of neuroplasticity.
Right, right. And I know you and I were chatting just before we started recording, and it's, I think those of us that are familiar with EMDR, which is really about reprocessing, memories and traumatic events, how are they similar in all of this?
Yeah, so it's interesting that, and I can maybe talk in a bit about some of the specific techniques that are used with treatment of neuroplastic pain, but I absolutely see EMDR as falling under that relevant umbrella because, yeah, essentially EMDR is helping us to reprocess not only, I would argue, not only on that cognitive and emotional level, but also on a body-based level. Right. The traumas that somebody has experienced, whether big T or little t. And of course, part of what is some of the premise of EMDR is that our brain has sort of gotten stuck in these patterns. And so EMDR is helping us to get unstuck so that we can start to relate to our lives in this new way. And that really is a lot of what's happening with treatment of neuroplastic symptoms as well. It's about helping our brain to get unstuck from these patterns. It's another term actually for neuroplastic pain is learned neural pathway pain. And sometimes I actually like that phrase even better because it really emphasizes to me the learning aspect and the neural pathway aspect.
Right,
and so importantly, if these pathways can be learned, they can also be unlearned. So even though we might feel like we're stuck, there's ways to get unstuck.
Right. So if somebody is coming with this type of pain, can you kind of describe for everybody how it's, I know you mentioned that it's not specific to any sort of physical injury or something physiological, but how does it kind of present itself and what does that look like?
Yeah. And so this is really the first important step, right? Is this approach that is even relevant for somebody? Because of course, if somebody does have a structural problem, and what I mean by that is there a tumor? Is there some sort of fracture that hasn't healed? Is there an infection that hasn't resolved or some kind of disease process? And so that obviously these things happen all the time, even tumors absolutely happen. And so we want to ensure that something that does have one of these structural causes and does have kind of a clear mechanism for treatment can be addressed if that is possible. Of course, when people are coming to me as a psychologist or coming to any other mental health professional or a coach who works in this field, they've probably already done all kinds of investigations that have been able to, at least to a certain extent, rule out that, yeah, there is no tumor, there is no fracture, there is no ongoing infection or disease process. Thus, again, there isn't any like clear indicator of tissue damage. Or sometimes, just to confuse things a little bit, there might be some suggestions of tissue damage, like somebody's got findings on an MRI that they've got a disc bulge, for example, in their back. But those findings don't always necessarily correlate with the symptoms that a person is having. So that's the first thing, ruling out, is there anything kind of physically present, observable in the body that could be the reason for this person's symptoms? But so often there isn't anything that's explanatory, which can be incredibly frustrating for sure. And so many people are told, we don't know what's causing your pain or your other symptoms. There's not really anything we can do. You just have to learn to live with it, right? Like such demoralizing messages really for anyone to receive.
Yeah.
But from a neuroplastic perspective, I always sound kind of kooky and cruel, I think, when I say this to people, but it's like, that's good news because it probably then suggests that it's more likely that neuroplastic processes are at play. Because if somebody doesn't have indicators of structural damage, tissue damage, disease processes, but they're still having symptoms, then that's a great time to start to be curious about, okay, so what's the evidence that a neuroplastic process is happening, or a brain-based, nervous system-based process. So this is where then what we're trying to do is rule in neuroplastic processes. And there's a few ways that we do this. And it's kind of by looking at, as we are always doing in mental health, looking at a person's not only current circumstances, but also their history. And so what we're really trying to get a better sense of is not only the kind of precipitating factors for like, why did the pain start in the first place, but what keeps it going, the perpetuating factors, and what might have been predisposing factors in a person's history that might, again, kind of make them have the kind of nervous system that's going to be more likely to respond to potential threats in their environment and then respond by generating pain. And again, the pain is absolutely real, just that it's not caused by tissue damage. It's caused by these brain-based processes instead. So we're ruling in by looking at things like how does a person's symptoms show up? Do they actually change quite a lot throughout the day? Or do they move to different parts of the body? Are they triggered by things that would otherwise be innocuous, like light touch or sunlight or something like that? And these actually, there's a whole system that's called the FIT criteria, which stands for functional, inconsistent, and triggered. So those are kind of the guidelines that we use just to help us try to make that determination between structural and more likely to be neuroplastic. And it's really about finding personalized evidence for each individual, right? It's not about me saying to somebody, oh yeah, you've got neuroplastic symptoms. This is what we need to do. It's really about like this process of self-discovery to understand this is like the clear evidence in my day-to-day life that it's actually highly unlikely that there's some sort of dangerous disease process going on in my body. And I just want to add as well that the other thing we're also looking at then is in terms of those predisposing factors, and this is where I think it becomes super relevant to those of us as therapists. We're looking at things like, what were your early life experiences? What are some of your personality characteristics that were learned from those early life experiences? So it doesn't have to be abuse and neglect, but it can just be growing up in an environment where we got reinforced for taking good care of other people, right? Like the kind of the common joke that most of us have been therapists ever since we were children. Right? Yeah. Growing up in an environment where we get reinforced for having high standards, for being really conscientious, for being people pleasing, all of these kinds of things. They can be great qualities, but they also just sort of create a nervous system that is going to be hypervigilant, perhaps, is going to be really attuned to other people's needs, but maybe less attuned to our own needs, all those kinds of things. So, and we're also looking at, what did somebody learn about emotions? Because this is a really important piece in this model too. Because if somebody learned it's not okay to be sad, it's not okay to be angry, it's not okay to express a difference of opinion, any of these kinds of things, that's also setting their nervous system up to perceive sadness is threatening, anger is threatening, difference of opinion is threatening, et cetera, right? So that's all going to feed into just kind of this like perfect storm of conditions, right?
Yeah, right. Yeah, I was just thinking, I think probably all of us have experienced somatic symptoms to, anxiety or extreme, situations in which, a body, we feel it in our body, that pit in the stomach kind of feeling. Yeah.
Exactly. Yeah. And this is the point. Like, these symptoms are just part of being human. I mean, from this model, anxiety is a neuroplastic symptom as well, because ultimately pain and anxiety, they're both serving the same purpose, which is to try to keep us protected, right? It's like something is threatening, so we need to have a response to that to keep ourselves protected, right? It's the fight, flight, freeze response.
Right.
And when it comes to chronic pain and other persistent symptoms, it's just kind of like the system's sort of working against itself now, right? This thing that's intended to be really helpful, to be protective, actually becomes the thing that's hurting us even more ultimately, because sadly, pain is painful. So even though it's trying to be a signal of like, hey, there could be something bad going on here, unfortunately, it can start to become the problem itself,
Right.
especially when we're
Right.
talking about things becoming chronic and persistent.
Right.
If you still haven't ordered her Valentine's gift, don't panic. Just hurry and go to 1-800-Flowers.com to save up to 50% on beautiful premium roses. What sets 1-800-Flowers apart from the rest are their premium first-cut flowers, backed by their 7-day freshness guarantee, plus same-day delivery when you need them. Right on time for Valentine's. This deal ends February 10th, so don't wait. Beat the clock and save up to 50% at 1-800-Flowers.com/podcast. That's 1-800-Flowers.com/podcast.
Let's talk groceries, specifically your groceries, with Instacart. You want your groceries just the way you like them, right? Well, the Instacart app lets you do just that. They have a new preference picker that lets you pick how ripe or unripe you want your bananas. Shoppers can see your preferences up front, helping guide their choices. Instacart. Get groceries just how you like.
Yeah, and unfortunately, pain is such a subjective thing, and that I can't just look. I could maybe tell by facial expressions or whatever, but you just can't look at someone and say, "Okay, they're in pain."
Yeah, and I think that's the other important piece, that like even the International Association for the Study of Pain, they include in their definition of pain that it's a sensory and an emotional experience, and that it's connected to actual or potential tissue damage. So like even in that definition, we've got the recognition that there are emotional processes at play, and that pain isn't only about tissue damage. Of course, sometimes it is, but it can also happen in the absence of tissue damage. And I think this is also really important, especially when we're talking about mental health populations and mental health professionals. Even if pain exists in the absence of tissue damage, it doesn't mean that somebody's making it up or faking it or imagining or malingering, right? It doesn't mean any of that. And kind of back to your point, Gordon, that just because we can't see it doesn't make it real. Like it's absolutely real. And just because it's being generated by our brain doesn't make it less real. It's absolutely real.
Yeah.
It can be incredibly debilitating. And it doesn't mean that it's tissue damage that is the cause. There can be something else, being our brain and our nervous system and how it's interpreting threat, that truly can be the cause, which I know is like, when I first learned about this, I was kind of like, what are you talking about? Like it seemed kind of mind-blowing at first.
Right.
It can be a big paradigm shift, especially from more traditional biomedical models of what's going on in our bodies.
Right. So I was just curious, can you give us maybe some case examples of maybe some folks that you've worked with?
Yeah, if it's all right, I'm going to give you an example of myself.
Okay. That's your prerogative. Yes.
So at the beginning of the pandemic, I injured my eye. I just accidentally hit my eye in the garage one day, had my glasses on. So my eye was protected, but it got injured. And so this led to what started to become excruciating stabbing pain in my eye. It was like a lightning bolt in my eye. Thankfully, it didn't happen all the time, but it would especially happen in the morning, like waking up, especially if like bright light was coming into the room. It was actually like a flashback in a way. It was like I was re-experiencing the original injury when I would have those symptoms.
Yeah.
So, of course, being the pandemic, I didn't go to a doctor or eye doctor right away because we were like being encouraged not to do those things unless it was a real emergency. And I didn't seem to have any, vision issues or anything like that, but I had this persistent pain that kept showing up in my eye. Eventually, after a few months, I was able to get it checked out by an eye doctor. She said, your eye looks totally fine. Like both of my eyes looked exactly the same. So, okay, great. But I kept having the symptoms. And I was like, I don't understand why this keeps happening, even though she's saying, basically structurally, there's nothing wrong. So thankfully, actually around that time, that's when I started getting more into learning more about and training more in this area of neuroplastic symptoms. And I was able to understand that it was my brain perceiving threat that was keeping these symptoms going. And also really importantly, it was predictive processes keeping the symptoms going. And that's another really important element of this model, that our brains aren't just reacting to what's going on, but they're actually predicting, because predicting is more efficient. And our brain's got a tough job. It's got a lot of things. It's on its to-do list every moment.
Right.
And so if it can predict, and more often than not, right, if it's got a decent batting average with its predictions, it's just going to keep making those predictions because it's just faster, simpler, just way more efficient, requires less resources to be predicting than coming up with like a new response in every such single moment that we encounter in our lives. So that's part of what was going on with my brain. There was this basically conditioned association that had been created, basically, right? Just Pavlov's dogs, where I would experience the trigger, right? So it's not like sunlight coming into the room was actually causing my pain. It was the initial injury had created these conditioned associations, but sunlight was triggering the pain to basically recur in my eye. And so what I was able to do was use this information to, number one, understand there wasn't anything structurally wrong with my eye, right? Even though the eye doctor had already told me that, it's just human nature to like continue to wonder, well, I don't know, maybe there is something. Yeah, right. And especially because it's my eyes, like the inside kind of my eye, right? You can't see that on like a bump on your arm or something. So
right.
Totally human nature to kind of doubt, well, maybe there is something going on. But number one, I was able to understand there isn't something structurally wrong with my eye. I was also able to start to better understand like this pattern of, okay, yeah, I didn't have the pain all the time, but I did have it at certain times of the day, right? These particular triggers. And I was also able to start to just kind of sit with those sensations in a different way, because of course I could now understand they weren't dangerous. It was just basically my brain being overreactive, overprotective, more importantly. And I could also reassure my nervous system, like even before I went to bed, hey, you know what? You're safe. It's okay. Even though the pandemic was still there doing its thing, causing all kinds of stress and havoc. But at least in those moments, I could reassure my nervous system that it didn't need to be trying to protect me with these particular symptoms, right? It didn't need to be trying to get my attention by creating these symptoms. I could basically tell it, hey, thank you, body, for trying to keep me protected. But I don't need the protection in this way.
Right. Was that process for you? Was it more of a cognitive change, or was it more of a somatic change that you in taking care of that for you?
Both.
Or both, maybe.
Yeah. And I think it always needs to be, and probably really all three, like somatic, cognitive, and emotional. That's when we're going to get the best results, because so much of this, and I think my example really highlights it, because, like I was saying, most of the time my symptoms showed up when I was like waking up from being asleep. So, and I think this is where there's a really helpful parallel with panic attacks and panic disorder that so many of us working in mental health are going to be familiar with, right? One of the hallmarks of panic disorder is having a panic attack out of the blue, or waking up in the middle of the night, having a panic attack, right? And so people will argue, well, how could that be psychological? I wasn't even conscious, right? I was sleeping. How could my thoughts be impacting, or how could this even just be stress? I was asleep. I was like having a good dream, maybe. And of course, it's because for sure stress plays a role, but it's not just about that. It's also about the conditioned associations that get created, right? And so a person can have a panic attack out of the blue or in the middle of the night, it wakes them up. And it's happening because there's something in the body that has been previously associated with having a panic attack, right? And we just have natural variations in our physiology as we're sleeping, and that can be enough to just trigger that association and then that response that the body has learned, right? So it's very, very, very similar to the model that we use for anxiety, especially panic attacks and panic disorder.
Right.
Yeah.
So really kind of challenging that part of our brain that's saying, okay, danger, danger, when in reality, there is no danger.
Yeah. And it doesn't mean that there isn't something to pay attention to. It's just that we need to help our brain and our nervous system recategorize those experiences and understand that, yeah, bright light coming into the room isn't dangerous. But maybe the existence of the symptom and the persistence of the symptom, maybe it actually is still really relevant to pay attention to, but not in this like hypervigilant, I need to get rid of it, and that's why I want to pay attention to it kind of way. I need to constantly be monitoring it way, but in a, hey, let me be curious about,
Right.
well, why is the symptom showing up, right? What is it maybe trying to communicate? What is it trying to tell me? What is it trying to signal? So, and I often talk about this as almost like the advanced stage of this process, because it's definitely not easy to start off with like, oh, let me welcome the pain and just, sit with it and have tea with it. It's like, yeah, that is going to be really challenging, especially when symptoms are really debilitating. But it's also true, in fact, I should say, and it's also true that symptoms are often communicating something important. And so if we can be willing to be open to that possibility,
Right.
there maybe is something really important that we can learn from that. And I will say, even though my lightning bolt of my eye symptom doesn't happen nearly as often as it did 5 years ago, 6 years ago, sometimes it does pop up. And when it does, it's a really great opportunity for me to pause and ask myself, hey, what's like going on, especially what's going on in my life that maybe I'm not giving as much attention to as I should. And that this is basically like a signal that my threat detection system is sort of getting a little bit overloaded. And so maybe I want to give it some extra attention.
Yeah, I know just talking with people that do have panic attacks or panic disorder, I kind of compliment them. You've got an amygdala that's just working really well.
Yeah.
And it can't determine between what's just a difficult situation versus a dangerous situation. It just responds the same way.
Exactly. That's what I often say to people, that our brain, like, first of all, as you know, right, our brains are wired for survival. In fact, wired first and foremost for just regulating our body, but that includes our survival. Our brain doesn't care about our well-being, really, right? Like, it just cares that we stay alive. It kind of doesn't care if we're happy and alive. It's just, it's like, hey, keeping you happy was not in my job description. Just keeping you alive is in my job description. So if we can understand that that's what our brain is trying to do. It's just trying to keep us, regulated. It's trying to keep us protected. And it's just going to do whatever it can do. And part of that is often being like extra conservative about what might be a threat. So our brain, right, people think maybe, like, if they think about this at all, that our brain is assessing threat in terms of like not a threat, maybe a threat, definitely a threat. But I would argue what's actually going on is not a threat and maybe a threat. And sure, definitely a threat falls into that case, but like the much bigger proportion is it's like better safe than sorry.
Right.
So let's just kind of put everything in the maybe a threat category, because of course, for our survival purposes, way more costly to think that something isn't a threat and then it actually is.
Right.
Versus the reverse.
Right.
Yeah.
Right. So what are the typical interventions and what do they look like?
Yeah. So that's a really important question. And it also speaks to, I would say, so how is this maybe a bit different from our more traditional approaches like CBT or even ACT or more like a relaxation, stress management kind of approach? And so those traditional approaches offer really great models and strategies for people. And what I would say is that this approach adds this really important piece of the learning mechanisms, the predictive processes, and the role of our subconscious, which includes emotions themselves, our symptoms themselves as potential sources of threat. So what these approaches are doing, first and foremost, they're starting from the assumption that there isn't tissue damage, whereas our more traditional like CBT or even ACT approach is probably not being quite as strong on that assumption. It's kind of going a little bit more with, well, yeah, maybe there is something damaged in your body. You're not going to be able to change that, but let's help you think about it differently and live your life as best you can despite those symptoms, right? And there are situations where that is very relevant, right? Like if somebody's got incurable cancer, that's probably the way to go about it, as opposed to, right? Let's just rewire the threat processes and the cancer is going to go away. Again, cancer's a structural diagnosis, so that's a different category. But if we know that a key difference then is we are starting from the premise that there isn't structural damage, and thus the symptoms can be reversible, and we're starting from this knowledge that the reason the symptoms persist, again, is not because there's something wrong in the body, but because it's how the brain is operating, then that can become our target. And so essentially the whole goal of any of the approaches that can be used is to help an individual learn to relate differently to any uncomfortable internal experience, whether it's the pain or other symptoms themselves, or also emotions, what we've learned about how to be a good person, how to be a good therapist, any of these things. And I hopefully, as my personal example highlighted, what I really did was I learned to relate differently to those symptoms that I was having in my eye, both in the minute and in the moment, and also more globally, seeing it from this kind of taking a different meaning from the symptoms. So the most popular approach in terms of a treatment is something called pain reprocessing therapy. And that basically includes this psychoeducation, always starting with that, about just making sure that people understand how pain operates, and then helping people to get out of this fear pain loop that gets created, right? Because we have symptoms, we are getting freaked out by having the symptoms, especially then getting messages like, you're never going to stop having these symptoms. And then that's going to cause increased fear. That's going to cause increased symptoms, because again, the symptoms are just a reaction from our nervous system to perceived threat. Well, then symptoms themselves are becoming threatening. And so we just get caught in this vicious cycle of fear, pain, more pain, et cetera, et cetera. So treatment is really about getting out of that loop. And so pain reprocessing therapy offers a variety of practices and perspectives for helping us to do that. There's also an approach called emotional awareness and expression therapy. And this has overlaps with pain reprocessing therapy, or PRT, but it also explicitly focuses on the emotional pieces and helping people to better identify and express emotions that maybe they've been suppressing, that they've felt they don't have permission to connect with, that it's dangerous to connect with those emotions. So still doing the same thing, helping us learn to relate differently to these uncomfortable internal experiences. It's just sort of going about it in a slightly different way and just kind of emphasizing more the emotional learning, whereas pain reprocessing therapy, to put this into generalities at least, is emphasizing a little bit more just kind of the learning around the physical symptoms and understanding we don't need to be as afraid of them. Again, it's very similar to like what we would be doing with treatment of panic attacks.
Sure. Yeah, Melissa, this is just fascinating stuff. And I know we've got to be mindful of our time, but tell folks, I know you've put together a course specifically for therapists that might be dealing with this particular issue. So tell us about that.
Yeah, thank you so much for raising that, Gordon. So of course, I just want to acknowledge there's all kinds of fantastic trainings. I've done most of them at this point. If somebody is interested in actually getting trained to do pain reprocessing therapy or emotional awareness and expression therapy, internal family systems is a great approach for this too, that I also use. But so I do not at all profess to be an expert in teaching other people how to do this work with their own clients. But what I recognized is that I think there is a really unique need for mental health therapists ourselves, health professionals ourselves, to have some resources that are specific to those of us who might have some of our own chronic symptoms. And I mean, I shared just one example of my own. I've had other chronic symptoms over the years, as again, all of us have to a certain extent, because it's just part of being human. So I created a course that I have affectionately called You Are Not Broken. And it is especially for other health professionals who might be struggling with their own neuroplastic symptoms. And what I've tried to do is incorporate in more detail a lot of the things that we've been talking about today, as well as the emphasis on some of the unique factors that are really going to be relevant for health professionals ourselves. And I just want to note that I actually created the course as an audio course because I think that, a lot of us have screen fatigue at this point.
Right.
And so much of this work is really about nervous system regulation. And of course, being a podcaster, fellow podcaster, there is so much value in just hearing somebody else talk. And there is kind of this unique intimacy that comes from listening to podcasts, right? As opposed to watching videos. And it is the kind of thing that you can do in concert with other activities of your day. So
it's my favorite way to do things.
Yeah. So I explicitly made the course in an audio format so that people can listen to it while they're walking, while they're laying down. Doesn't require sitting at a computer or even looking at a phone. Don't need to be looking at a screen, just need to be listening. And hopefully it also helps the experience feel a little bit more like there is this connection that can also actually be part of the quotes treatment, right? It's not exactly the same as one-to-one therapy, but there's of course this co-regulation that comes from hearing other people's voices. So so it was an intentional decision on my part to make it.
Well, that's so cool. So where can people find it?
Yeah, just through my website, drmelissatiessen.ca. And I also have a free newsletter if somebody just wants to hear some more of these kind of stories about how pain works and how we can use our brains to help us make a difference.
That's great. That's great. And we'll have links in the show notes and the show summary for everybody to get to this easily. But, well, Melissa, I'm sure I will have you back again, and tell folks your podcast again.
Oh, yes. Thank you. So again, with my colleague, Dr. Karen Dick, we have a podcast called Intentional Therapist, Putting You in Your Schedule. And it's all about trying to rewrite how, as therapists, we think about self-care. Because again, there's so much in our training that kind of makes it hard to actually care for ourselves the way that we should, and to care for ourselves the way we tell our clients to care for themselves.
Absolutely.
It's really about giving ourselves more permission to do what's going to be best for us, which is very, very relevant to neuroplastic symptoms too.
Yeah. Well, that's great. That's great. Again, we'll have links to the podcast and everything in there. And Melissa, hope to have you back on again. And thanks again for joining me.
Yeah, thank you so much, Gordon. I hope this information will just spark some curiosity at the very least.
Yeah,
for
I think it will. I think it will. Thanks. Well, a big thanks to Dr. Melissa Tiessen for being on the podcast again. This is just, I think, kind of cutting edge stuff. The more, I think about where we were when I first got into being a therapist, and just all the new things that are coming out around somatic therapies. And I know for some people that doesn't seem like it's new stuff. It's just what they've known. But I just think back, and I'm dating myself, when I first went through graduate school and just started learning all the different areas of what it takes to be a therapist, and just learning about the science later on of brain science and just neuroplasticity and how all of that affects the therapy work that we do. And so, again, big thanks to Melissa for being willing to put this out there and just really sharing her own experience just personally, and how this this particular topic has affected her. So be sure to check her out by going to the show notes, and you'll find links there for her website, and also just to find out more about her and the work that she's doing in this particular area. And also, before we go, I'd love for you to check out TherapyNotes. If you'll go to practiceoftherapy.com/therapynotes, you can find out more about them. And if you'll be sure and use the promo code, just Gordon, Gordon, you can try them out for 2 months for free. They're who I use in my practice, and I'm absolutely impressed with all the new features they continue to add and how they keep improving their platform. So be sure and check it out, practiceoftherapy.com/therapynotes. And also be sure to take time to subscribe to the podcast or follow the podcast, however you want to call that, wherever you might be listening to it, whether it's on Spotify or Apple Podcasts or any of the other podcast platforms, you can find us there. So be sure and check it out. And also I'll mention, if you would like to watch a video or get a visual of these podcasts, we do have a YouTube channel, and it's under the Psychcraft Network. And you can check that out by going to YouTube and just type in Psychcraft Network, and you can find this podcast along with the other podcasts that are part of the network. So be sure and check that out. So take care, folks, and we'll be back with you again for another episode of the Practice of Therapy podcast. You have been listening to the Practice of Therapy podcast with Gordon Brewer, part of the Psychcraft network of podcasts. Please visit us at practiceoftherapy.com for more information, resources, and tools to help you in starting, building, and growing your private practice. And if you haven't done so already, please sign up to receive the free Private Practice Startup Guide at practiceoftherapy.com. And to find more great podcasts like this one, please visit the Psychcraft Network at psychcraftnetwork.com. The information in this podcast is intended to be accurate and authoritative concerning the subject matter covered. It is given with the understanding that neither the hosts, guests, or producers are rendering legal, accounting, or clinical advice. And if you need help in these areas, be sure to find the right professional to help you with these things.
Big news! Wayfair's President's Day clearance is on now, and you can score tons of huge deals. Like Wayfair's best deals since Black Friday. Right now through February 16th, you can score up to 70% off everything home at Wayfair. Like up to 50% off mattresses with fast and easy shipping straight to your door. Plus amazing flash deals on President's Day. Shop Wayfair's President's Day clearance now through February 16th.
Wayfair, every style, every home.